Yeah, welcome to my channel. So subscribe to my channel, please. Tutorials Abraham. Today I'm going to talk about treatment failure in HIV and AIDS. So it's basically the inability to maintain or achieve suppression of viral replication to below detectable levels, or undetectable levels, leading to a failure in achieving desired clinical outcomes. So we have types. So the first one is virological failure, so inability to achieve or maintain suppression of viral replication to undetectable levels. So usually inability to achieve suppression of viral replication below 50 copies per mil. So under virological failure, we have what we call indicators. We can say maybe like causes, indicators. No, these are indicators. So incomplete virological response. So HIV RNA of above 200 copies. Yeah, so incomplete. So the HIV keeps replicating to above 200 copies per mil. Yep, per mil after 24 weeks. So these are maybe signs that someone may soon start experiencing virological failure. So if there's incomplete virological response, so HIV virus keeps replicating after 24 weeks. So 6 months of starting the therapy, it keeps replicating. So, and then the second indicator is a viral rebound. We call it viral rebound. Yes. So maybe after prior suppression, so the drugs were just working fine. From there, there's an increase of 200 copies per mil of HIV RNA. Yes, so this can indicate that the patient is beginning to experience virological failure. Yeah. So what are the causes of virological failure? Causes: we have non-adherence. And then it could be to drug resistance. But the major cause is poor adherence. And then it could be also due to poor pharmacokinetic profile. So meaning the drug is poorly absorbed, poorly distributed, poorly metabolized. And then it could be due to drug interaction. Yes, for example, if a patient is on maybe AZT, 3TC plus lopinavir, ritonavir, and then maybe has developed TB, and then you have to double the dose of lopinavir, ritonavir, and then you don't double, and then this can because under TB there's a drug called rifampicin. This is a cytochrome P450 inducer, so it may increase the metabolism of ritonavir. So this, yes, this is just an example. Yep. So but this is virological failure. So the second one we're going to talk is immunological failure. Immunological failure. So immunological failure is the failure to achieve or maintain an adequate CD4 cell count response despite virological suppression. So the poor to maintain, yes, the failure to maintain adequate CD4 count, adequate CD4 count despite being on treatment. So what are the indicators? Indicators, we have what we call failure to increase CD4 count by, so failure to increase CD4 count of 50 to 100 cells per microliter in the first year of antiretroviral treatment. Yes, or persistent CD4 count below, or persistent CD4 count below 200 cells per microliter after 1 year of RT. Causes. So under immunological, it could be causes. So causes could be what we call advanced HIV infection or disease, HIV disease. Yes. So co-infection. So this is concurrent infections such as TB, hepatitis, so concurrent infections that impair the immune system. Yes. We've also age. So under age, older patients may have a slower or less robust CD4 recovery. So older patient may have a slower or less robust CD4 recovery. So also drug toxicity. So if they affect bone marrow, or other components of immune system. Then last, we're talking about the clinical failure. Clinical failure. So it's basically the occurrence of HIV-related clinical events. So occurrence of opportunistic infection, of persistent infection after 6 months of ART treatment. So usually indicators, the indicators we have what we call development or recurrence of AIDS defining condition. AIDS defining conditions. So I think maybe TB, cryptococcal meningitis. So causes of clinical failure: virological and immunological failure. Leading to clinical progression, or suboptimal adherence. Poor adherence affecting overall treatment efficacy, drug resistance, inadequate ART regimen. So how can you prevent treatment failure? So prevention of HIV treatment failure. Prevention and treatment or management. So number one, you have to assess adherence and improve adherence. So review adherence with the patient, address barriers and provide adherence support. Consider using adherence aids such as PO boxes, alarms, or counseling. So address adherence barriers such as high PO burden. So if the patient is on maybe three-day regimen, maybe it takes the drug 3 times or 2 times, you can shift to regimens which concern which is once daily or even injectables and are available. They'll also address the side effect, very concerning. And then the second one, you can testing resistance. So perform genotypic resistance, testing to identify resistance mutation. The earlier the better. Use resistance test result to guide modification in the ART regimen, and then optimize ART regimen. So you have to optimize ART regimen and switch to a new regimen based on resistance testing result. You can switch to a new regimen based on the resistance testing. Use a regimen with at least 2, preferably 3 fully active drugs. So you can give a regimen of 2 to 3 potent drugs. Like in USV, there are this what we call Cabenuva. Is a combination of cabotegravir plus rilpivirine. I think this is injectable. So there's integrase inhibitor plus non-nuclear salivary transcription inhibitor. But the Nucleoside reverse transcriptase inhibitors remains a very potent and efficacious drugs. So regimens like AZT plus 3TC backbone or TDF plus 3TC or FTC or Abacavir plus 3TC or FTC. Sometimes they give AZT plus TDF plus 3TC plus, for example, Reutegravir. So the backbone is very important. So for nucleoside reverse transcriptase inhibitors, the likes of TDF, AZT, 3TC, FTC, ABC remain the backbone. Yes. And then number 4, you can address the pharmacokinetics, kinetic barriers. Yes, so review concomitant medication for potential drug interaction, assess for issues with drug absorption, e.g. gastrointestinal conditions, monitor and follow up. So this monitor and follow up. So under follow up, so you can test for viral load, CD4 count, and then drug toxicity, also side effects management, and then lastly, manage what we call co-infection comorbidities, co-infections and comorbid condition. Identify and treat co-infection, e.g. TB, hepatitis. Manage comorbid condition, e.g. cardiovascular disease, mental health issues. So manage all other conditions which the patient may have, such as cardiovascular diseases, e.g. hypertension, ischemic heart disease, myocardial infarctions, valvular diseases, maybe heart failure. You assess all this. Diabetes, mellitus, and then if TB is present, maybe candidiasis, other infections. So in conclusion, treatment failure in HIV is a complex issue requiring comprehensive approach to identify and address the underlying causes. Close monitoring, patient education, and adherence support are critical to optimize treatment outcome. So this area should be focused. Number 1, close monitoring. So be close to the patient. Number 2, patient education. You can encourage patients to join groups on maybe Facebook, WhatsApp, etc. of others living with HIV. And then adherence support. Create a mutual relationship with the patient. Then if there are issues of side effect, eye, pill burden, yes, co-infection, other related. So thank you so much, and God bless you. And please subscribe. Subscribe to YouTube channel. Facebook. Tutorials. Thank you so much.